So today, I hope you guys got your running shoes on. We're gonna be talking about breaking the bone barrier. Gonna be an interesting aspect to look at it. And really, this is about something we all see. But maybe you don't always think about deeply, or you stop to reassess. Osteoporosis is everywhere in our practice. But the way we manage it and follow it and sometimes miss it, that's where things get interesting. So that's my disclosure. I participate in many advisory boards and grants, research, and speakers. So let's start with why this actually matters. Sorry, I don't mean to not look at you guys too, but what I want you to walk away with today is not just the information I will present you, but clarity on how this actually applies in practice. We will touch on the biology, but only what you need to make sense of for the treatment. We will go through where different treatments fit, and just as importantly, where it can go wrong. We will spend a bit of time on biosimilars, and at the end of the talk, the goal is really this, where we, as pharmacists, actually make a difference to our patients. So before we get into that, I would like you guys to start with a quick poll. So if you don't mind, use your camera. We're gonna pop into some questions. Perfect. As soon as you start, it will take you through 30 seconds to read the question and choose the answer. The first question is, a patient has been on denosumab 60 milligram every 6 months for 3 years, and he wishes to discontinue the therapy. What's the most critical action? A, simply stop. B, transition to oral or IV. C, start calcium and vitamin D. Initiate a 2-year drug holiday before assessing. Perfect. Oh, did I? Oh, I'm sorry. I think I jumped on the first one. Sorry. You guys started on the first one. My bad. Okay. That was another question. Okay, perfect. Oh, which of the following best describes the pathophysiology of postmenopausal osteoporosis? Increased osteoblast, decreased osteoblast, normal bone remodeling, increased bone formation. Okay. Wow. It's just interesting to see all the answers. Perfect. And the right answer is B. A 50-year-old woman taking prednisone 10 milligram daily and ask about her fracture risk. At what T-score threshold should osteoporosis therapy be initiated in a glucocorticoid-induced osteoporosis? So minus 2.5 or lower, minus 2 or lower, minus 1.5 or lower, or like minus 1 or lower. Boom. The right answer is C. Which of the following medication is most likely to cause drug-induced osteoporosis? Metformin, lisinopril, omeprazole, atorvastatin. That's PPIs. Which of the following patient meets criteria for very high-risk osteoporosis, which requires anabolic therapy as a first-line treatment? A 70-year-old with minus 2.6, no fracture, 68 with minus 2.8, rest fracture 5 years ago, 72 with T-score minus 3.2 with recent fracture, or a 65 with T-score minus 2.5 fracs is 21. Oh, amazing. We have a 2/3, and C is the right answer. Sorry, this is the one that I jumped to too early. A patient been on denosumab 60 milligram every 6 months. What do we do to discontinue therapy? Stop it, transition it, calcium and vitamin D, or drug holiday? And I need you to remember this slide specifically. It's one of the most important points we're going to visit during the talk. Okay, perfect, amazing. B is the right answer. A 74-year-old stage 4 CKD osteoporosis treatment. What do you go for? Alendronate, zoledronic acid, ibandronate, denosumab. So biphosphonate is contraindicated for creatine clearance less than 35. Which medication has a black box warning contraindication with recent MI or stroke? And that would be C, romosozumab. Okay, last question. What is true regarding the osteonecrosis of the jaw with osteoporosis medication? Only with biphosphonate, dental procedure should be avoided indefinitely, risk is higher with high-dose IV, or spontaneous hypomedication discontinuation resolves. Okay, amazing. C, which is the IV biphosphonate. Okay. The last one is where I will start my talk. Rate your comfort level after answering those questions, how you feel about managing osteoporosis for your patients. Thank you so much, guys. I really appreciate you being active and interactive with this. And this is the point. So, again, this is just to get a sense of where we are at and how comfortable we are. So let's talk about osteoporosis. Just to level set, osteoporosis is not just about low bone density. It's really a combination of reduced bone mass, structural deterioration of the bone. And what that translates into clinically is weaker bone, higher fracture rate. Unfortunately, most patients don't feel anything. There is no symptoms of osteoporosis until the first fracture. And that's At that point, we are already behind. And I'm going to shock you with the next 3-4 slides. When you look at the numbers, you'll find that the fragility fracture are actually more common than heart attack, stroke, and breast cancer combined. And we tend to think of those conditions as high priority, high urgency, but osteoporosis often doesn't get that same level of attention. And it's not just about fracture, it's about what happens after. And if you don't mind, think about it if you knew that. Within a year of a fracture, you're looking at around 14% mortality rate. It's the same range as a heart attack and a stroke. And if you focus on hip fracture, the number is very, very concerning. You're talking about 1 in 5 women with a hip fracture and 1 in 3 men will die within a year. And it is a serious health event, and yet we don't always treat it. We don't even think of it that way. So we have opportunities out there, but we are clearly missing it too. If you look at what happened after a fracture from a healthcare point of view, 5 out of 6 patients don't even get a bone density assessment within a year. Before the fracture, the majority were not on therapy. After the fracture, very low actually started treatment. Just 1 extra after a fracture will get a treatment. So this is not a knowledge gap. Like, we have knowledge gap, but not just knowledge gap, it is a follow-through gap. And by that point, the outcome are very, very bad for our patient. So, the last one, another striking comparison. After a heart attack, 80% start on therapy to prevent another event. After a fracture, less than 25%. Remember, at 80-20, unfortunately, 20% receive treatment. So we can recognize the pattern. The difference is where a lot of that problem lies is how we react to it. So before we talk about treatment, I'm going to take you back to school. We're just going to run with this. So I hope you guys are paying attention to me. I'm going to wake up with this. Okay, like 101 osteoporosis. Healthy bone, there is a balance between two. It is either bone formation and bone resorption. If I ask you to remember 3 things today, which is I will ask you 3 things, after this, I'll stop you and I'll tell you what is number 1, number 2, number 3. This is number 1. And if you take one thing, take the names. Osteoclast, I call it the destroyer, responsible for breaking down the bones. Osteoblast, B, is for the builder, and does build new bones. Those two constantly work in imbalance to maintain the bone strength. Osteocytes are the regulator, we call them the manager. So we have a destroyer, we have a builder, and we have a manager. And that manager helps coordinate that process. The key signals that make those work are the next 3. So you have the rankle, and I call it the on switch for the destroyer. And you have the OPG, and that's hit the brake, also for the destroyer. On the other side, you have the sclerostin. It's an off switch for the builder. If you can see that the majority of those ones are going to cause bone destruction. So again, you have the destroyer, builder, manager, rankle on switch to destroy, the brakes, and finally the off switch to build more. We'll zoom in on the bone resorption, on the bone destruction, and that's the key pathway. So we have the osteoblast and the osteocyte release the rankle. Then the rankle then binds to the rank receptor. Rank receptor is actually activate the osteoclast or the destroyer. Once that binding happens, the osteoclast becomes activated and the breaking down starts. The second part of that image, which is the braking system. Osteoblast, the builder, released the OPG, which act as a brake or a decoy to stop the rankle from activating the osteoblast. When that happens, activation is blocked and no bone destruction happens. So this is the problem. When this balance is disturbed, you have, and we will see the problem, you have more destruction and less building up. With that, the bone structure goes weaker, more fragile, and clinically, this is a higher risk of fracture. Okay, how do we diagnose this? Again, this is the second thing I hope you guys take home with you, which is very simple. It's a 3 steps. We start with the first one. Did your patient have a fragility fracture? What is a fragility fracture? It is a low trauma fracture from standing up or lower, especially in the spine, in the hip, or the wrist. That alone is enough to diagnose osteoporosis. If you don't see that, the second one is low bone mineral density. So we talked about it. It is minus 2.5 or less straight diagnosis. And the third one is the fracture risk assessment. We use a tool like the FRAX, and I'll show you how that works. But again, that is it. Less than 1 T-score, normal. Between -1, -2.5, osteopenia for women postmenopausal and men over 50. Osteoporosis is -2.5 and lower. This is how they do the DEXA. We're not going to go there. This is a little bit too academic. I use the FRAX in my pharmacy when I do med-check. I would advise you to. It's an amazing tool. It is actually allows you to estimate 10-year risk of fracture with or without the bone density. So we can do it in the pharmacy. In general, high-risk patient is over 20% to get major osteoporotic fracture or 3% or higher to get a hip fracture. So use it as a guide. It will direct you. Another piece to consider as pharmacists, and we are really good at it, is what medication will increase that, what directly, indirectly, or cause fall, which is a very high risk for fracture. So let's just focus firstly about postmenopausal osteoporosis. Again, it's driven by a few factors, mainly the lack of the estrogens as a postmenopausal, and this is when bone density is only one part. You're having a changes in bone turnover, structural, and all of this is affect how strong the bone is actually is. So when we say osteoporosis, we're talking about overall bone quality. This is how we approach the diagnosis. Again, it's the 3-step, and we talked about it: fracture, bone density, and the risk of fracture. The second diagnosis is osteoporosis in men. And I showed you it is way more risky actually than in women, but it is under-recognized. Men usually don't get assessed for osteoporosis, and when they do, they don't get treated for it. The pathophysiology is actually exactly the same as in men, which is, don't know if that's gonna shock you or not, it's lack of estrogen. Because estrogen blocks the osteoclast, blocks the destroyal. When the lack of estrogen, the destroyal just go full on. The difference is men's bone are way stronger than women's bones, so it takes time to get in effect. You guys know for sure that the testosterone gets aromatase into the estradiol, and this is the main effect of the whole andro hormones and testosterone, estrogen in men. The third one, which is the most common secondary cause of bone loss, which is glucocorticoids. To summarize it, it is a higher risk on top of all the risk we talked about. half of the patient on long-term steroids will be affected. The fracture risk is significant, and it happens at a higher BMD level compared to the typical osteoporosis. So who is at risk of glucocorticoids? One, higher doses, longer duration, recent use of glucocorticoids. Two, the effect of the steroids, like muscle weakness and hormonal change, add to the risk. Third, the underlying condition, why they are on glucocorticoids. So we're talking about rheumatoid arthritis, inflammatory bowel disease, which independently happen. I will add one more to it, is usually they take PPI. Guess what PPI does to osteoporosis? So the risk is way combined when glucocorticoids. We're not going to dig deeper into this, but you guys got the idea. The difference, and this is another piece of information, patient on glucocorticoids, the T-scoring doesn't need to be minus 2.5 or more. 1.5, minus 1.5 or more is a trigger, or if that person is a higher risk of fall. Okay, now we'll talk about the fun part, which I'll go even faster because this is what we do. Treatment decision actually start on risk stratification. Back when I was at school, when you say it's first line of therapy, second line, we don't think. We just go at it, this is number one, this is number two. This changed because each patient, based on their risk, gets a different treatment. And that's kind of, if you guys look at it, cardiovascular, osteoporosis, diabetes, it's based on how much risk that patient have. So the guidelines clearly separate patient into high risk and very high risk. You can imagine you go more aggressive for the very high risk versus the high risk. So we're talking about the same. Recent fracture, multiple fracture, very low BMD, will qualify that patient to a very high risk, and we go very aggressive in treatment. There is an algorithm for each indication that we talked about. I will send that presentation to everyone who would like to have it, just to give you an idea. So again, so many that they like to make it complicated. I love this algorithm. And it is literally, took me also back to school. It's a chart, you follow it, and you will find the whole arching idea is starting point, always assessing the risk. From there, management is guided by that risk. For intermediate risk, we typically start with biphosphonate. As the risk increases, treatment becomes more aggressive, intensive. High-risk patient require escalation, denosumab or other agent. Very high risk, especially those with recent fracture, we go after the anabolic, and after the anabolic, it is limited. It's either 1 year or 2 years, but as soon as you finish this, you flip them to a step-down treatment, or else you're gonna lose all the added bone density you gave them for a year. So this is all the medication, we know that one. Again, back to pathophysiology. This is just to tell you where each medication work. And quickly, we're just gonna point out that biphosphonate is like poison to the destroyer, to the osteoclast. I keep saying destroyer just so you guys remember it. It is a poison, it make it break down or it doesn't work proper. Raloxifene, as if you got your estrogen back, so it also stops the destroyer from working. Denosumab, it works on the rankle, blocks it, so the rankle does not activate the destroyer, so you have that balance back and you do not lose. The anabolics, they work on the other side, they work on the builder. So the teriparatide and apalparatide, they work as a parathyroid hormone temporarily, so they increase the bone formation. The romosozumab, it blocks the sclerostin, which actually slows down the bone formation, so it increases the bone formation. That's how each one works in detail, so we'll skip on that too. This is the third piece of information that I want you guys to take from today's talk. It's very important because we forget about it. What we call it the rebound. So, when denosumab is discontinued, we get something called the rebound effect. And this is not just a gradual loss of the effect. It's actually a biologic process. Once the drug is stopped, the rankle is rapidly reversed. Within 6 to 12 months, whatever we did, gonna go back and it's gonna get even worse. So clinically, we have to be very vigilant about when they take their injection, and if they stop it, it's worse than they started on that medication. How do we manage this? The key principle is, again, denosumab should not be stopped, should not be late. If so, then without transition to another therapy, which is the biphosphonate, we're gonna have a problem for that patient. The second concept is the biphosphonate holidays. Because biphosphonate stays in the blood for a long time after, some patient can safely take a break. Is it everyone? No, not everyone. It's the people that we assess after 5 years, are they better off or are they in the same risk? If they are in the same risk, we might stay. Are they getting worse? Then we need to escalate. So it's like everything. It's not fixed 5 years holiday. No, it is clinically based on that patient and their health. So as pharmacists, we love that. We are the only one who talk about the non-pharm options, which is very important. Calcium and vitamin D, very important. Weight-bearing, exercise, smoke cessation. So, now we talked about that medication. We're gonna have to touch what is biosimilar. Biosimilar is a biologic that's highly similar to an existing reference product. Importantly, there are no clinical meaningful difference in terms of safety, efficacy, or quality. There's large complex protein produced in living systems, so they cannot be the exact copy, so we cannot call them generics. That's why biosimilar is not considered generic. They go through a different, more rigorous approval process. And this is the process in Canada to get approval for biosimilar. That brings us together to the product we're talking about today as well, which is a very practical example in Canada, CTP41, which is called the Stopiclo. It's the biosimilar to denosumab. Same active molecule, same mechanism of action. So clinically, we expect the same effect. It's delivered the same way, 60 milligrams sub-Q every 6 months. And the indication mirrors the reference products, postmenopausal osteoporosis in men and glucocorticoid-induced osteoporosis. For them to get that approval, they had to run stage 3 clinical trial. And that is proved that it is similar, comparable in efficacy, in safety, in immunoresponse, in pharmacodynamic, and in pharmacokinetics. The outcome by the end of that trial was that it is equivalent to the denosumab in primary measure efficacy and pharmacodynamics, efficacy in safety and endpoint. Okay, this is the best part. That is, I love about this, is what can we do as pharmacists in osteoporosis? So, we talked about adherence, but I just want to tell you, adherence is the biggest problem with osteoporosis. Compared to any other chronic disease, persistence with therapy is significantly lower on osteoporosis. Non-adherence, number one, increased the fracture up to 30 to 40%. This is where we actually can play a critical role. from patient education, follow-up, continuity of therapy. And this is not just me coming up with this. There is many, many clinical trials and paper published that talking about how adherence can be improved with the right intervention. Most effective is multi-component: education, follow-up, patient engagement, simplifying dosing, longer interval therapy, regular monitoring, even remote support. And the most important, pharmacist-led intervention consistently improve adherence and improve outcome. And this is a practical example, and this is, I have to give it to the Stop Clo team, that they actually run an adherence program. It's about building system to support that adherence we are talking about. It helps ensure patients stay on track with their injection and follow-up, and importantly, it also supports the pharmacy. They help you to do it, and they support you doing it, recognizing the role that we play in monitoring adherence. If you guys have question about that, you can ask Conrad after the talk in the breaks about how that program works and how you use it in your pharmacy. Okay, you can take a breath. This is the last. But this is really how I see it. This is the opportunity to build a structured, high-impact program within your pharmacy. A program that identifies patients early, optimize their therapy, ensure adherence, and follow them as they grow. From a patient perspective, this is high-quality, specialized care. From a clinical perspective, this is directly improve outcome and reduce the fracture. And from a pharmacy perspective, this is what you can do to have a sustainable, reimbursable, and scalable program. So it positions the pharmacy different. It makes us as an active player in providing care for our patient. Not just a dispensing point, but a clinical hub for a chronic disease management, which we have many of those. So this becomes a win for your patient. It becomes a win for the healthcare system, and also a definite win for the pharmacy. And to be honest, this is exactly how I believe the future of our profession is heading. With that, thank you so much.